I became a physician after a lifelong dream of going into medicine. It started at a fairly early age, probably back in grade school, and that was always my dream for a profession, and that's how it happened. Most common surgeries that we see in this area are back and neck problems. There's also a lot of head injuries because of the recreational activities that are very popular here. All-terrain vehicles, snowmobiling, skiing, horses, and there's a lot of head injuries as a consequence of that type of activity. One is for degenerative disc disease, which is very common, spinal stenosis, trauma, or athletic injuries resulting in spinal problems. We have different protocols that are geared to, first of all, conservative care in almost all of them, to see if the problem can be eliminated or relieved with non-surgical options. Therapy, injections, chiropractic, even acupuncture. We also do have surgery that sometimes has to be done to fix the problem, and that's all incorporated into these various programs. I look at medicine somewhat differently than many of my colleagues. I think the body is a different sort of an organism that we don't truly understand as well as we think, and I think there's a lot of wisdom in these other forms of medical treatment that have been around sometimes for several thousands of years, and I think they know stuff we don't know. When we get to the point where surgery becomes a realistic option, that's discussed with the patient, usually family members that come in with them. We will tell them why we think the surgery is. If there are other options, we'll go over them, but usually they've exhausted those. And we try to give them a fairly realistic expectation that it's more than just the surgery. A lot of times it involves lifestyle changes that are forever, and they got to really change how and why and what they do to prevent the problem from reoccurring. Surgery is the last resort, except for in those cases where it's a neurological emergency, where if the surgery is not done, they're going to start to lose function in an arm or leg or both arms or legs. The tests that we use to diagnose these problems start with sometimes just basic x-rays, CAT scan, MRIs. We often will do injections to try to isolate the source of the pain. There are discograms, and occasionally even more elaborate studies involving the electrical function of the nerve and muscle themselves. I think most of the forefront changes are really in technology. As an example, if you had a fractured spine 20 or 30 years ago, you could have spent months in bed. Now with the technological changes and the instrumentation that we use during surgery, the patients are up the following day walking. A lot of the techniques we use are somewhat minimally invasive compared to regular surgery. Many of them are different types of injections which can relieve the pain with just the insertion of a small needle. We don't have to make big long incisions like we used to. Even removing discs can be done now through a small incision that's an inch or slightly longer, where in the past they were 3 to 4 or 5 inches long. The recovery time is generally shorter and less post-op pain associated with those smaller incisions. We work with other doctors through referrals. They can call our office directly, and we can often see the patients within 24 hours if it's an emergency. And we accept most insurance plans, and there are really very few obstacles to getting the patient in.